See, well, we have a very full show today. With us in studio now is Dr. John Mitchell, the president of the Mississippi State Medical Association Board of Trustees. Thank you, Dr. Mitchell, for being with us. Good morning.
Glad to be here. Thanks for having me.
Now, did you drive in, or do you live in Pontotoc, or are you here in Jackson now?
I live in Pontotoc, but because of my work here in Jackson as the director of the Mississippi Office of Physician Workforce, I live here Monday through Friday.
Okay.
And I get to go home on weekends.
Well, that's. I'm glad that you didn't have to make it by 7:20 leaving Pontotoc. That'd be a heck of a morning.
I just drove over from the reservoir.
Okay. Well, I'm here on the C Spire text line. Some people have warned us there's a lot of fog in Walthall County, so I don't know where it is elsewhere in the state, but that'd be a long, foggy drive this morning.
It was a good drive over this morning.
Well, if you've got questions for Dr. Mitchell, you can be part of the conversation on the C Spire text line at 601-879-4395. So, do you still practice, or are you full time with the Office of Physician Workforce?
I'm full time with the Office of Physician Workforce since 21.
Okay.
Up until that point, I did some clinical work through the university, and after 2020, which we all know what happened,
right?
Then I became full time at the Office of Physician Workforce, and partially because of the amount of work that kept increasing, because we've built a number of residencies throughout the state of Mississippi to train more primary care physicians.
Talk a little bit about what that office does, what the focus is.
Well, the focus was, as we approached Governor Bryant, who was Lieutenant Governor at the time, and he had a vision of increasing the physician workforce in Mississippi, because we knew that we were 50th in the nation in a per capita basis. But not only were we 50th in per capita, we also had a maldistribution of physicians concentrated in the metropolitan areas. So the goal was to train physicians in areas of need, and with the statistical background that they typically stayed close to where they trained, and that's been the case. So we scattered residencies in family medicine, internal medicine, emergency medicine, and have even built one psychiatry residency in the state. So we're trying to address not only the physician workforce need, but also the distribution. And we've moved from 50th to 49th in total physician workforce. So
and is the focus
like
there
turning a Titanic? It's not.
There's a lot to change. It doesn't happen overnight.
Change, right.
But is the focus there is trying, in part, to get more doctors in rural areas?
Correct.
Is that sort of the thinking?
Well, we know that statistically, like I said, that physicians stay where they train. So if you put the training in the rural areas, and considering you live there for a matter of 3 years of training, you build up a relationship usually, and sometimes build families. It's not nearly as daunting to remain there, and because they're familiar with the territory and it's not an unknown. So, and that is happening. This 23, we built a residency in Greenville, Mississippi, in family medicine. We graduated 7 residents.
Really?
4 of those have stayed in Mississippi, 2 actually in Greenville, 1 in Louisville, and 1 in another part of the Delta. And one of the others is actually doing some locums in the state. So, that's step 1.
That's interesting. Are most of those people, are they Mississippians who have, or do they come from all over?
It's a mixture.
Okay.
In new programs and new startups, and oftentimes it's more out-of-state people, graduates from other programs, international graduates. But we do have a mixture of Mississippians, and that phase is growing because we have 2 medical schools, with
William Carey and
right.
the university.
And so it's more opportunities to stay here, plus more familiarity with the programs. We hope that even grows more.
Now, you're the president now of the Mississippi State Medical Association Board
Correct.
of Trustees. For folks who don't know, what exactly is MSMA? What do y'all do?
Well, first off, I'm the president of this Mississippi State Medical Association. We actually have a board chair.
Okay.
Rod Givens is the chair of the board of Mississippi State Medical Association. But the Mississippi State Medical Association represents physicians of all specialties all across the state. We're the voice of physicians. I think at the Capitol and for Mississippians, we're at the national level through the AMA.
So y'all focus on sort of advocating for doctors at the legislature as they think things through.
Yeah, and I'd like to rephrase that in the sense
Sure.
that I think we advocate for patients by way of advocating for physicians, because physicians take care of patients, and patients are really the focus. But all things that we primarily focus on, et cetera, that are good for patient care as a result are good for physicians as well.
Okay. Talk, if you don't mind, tell us a little bit about sort of collaborative medical care. I understand that's going to be a focus of some sort at the legislature this year.
Not just this year, it's every year.
Okay. What is collaborative medical care?
Well, collaborative is team-based care. I mean, it's like being on any kind of sport team or otherwise. You have a conglomerate of individuals with one focus in mind. In this case, it happens to be patient care. And so collaborative care is that team focusing on the patient and working together collaboratively and efficiently and effectively.
Okay. And is that something that requires legislative action, or is that more just a growing approach in healthcare these days?
No, I mean, we have physician extenders that's been around for a long time. I did military service before I went to medical school, and so I've been associated with physician assistants, nurse practitioners, and other ancillary people on the team, because medicine's a team sport. We need all the team working together under one captain or one leader. And I think that where we get into each year, in the sense we lose focus on what we're really struggling for, and that's patient care and safety. And so the fight is always over independence. But we believe as physicians that the physician-led team is the most effective, safe approach to patient care. Licensure boards across the state, across the country, and et cetera, are principally assigned patient safety as their, I think, their primary focus. And so in that case, we think that a collaborative approach puts a safety net in all the processes, both in PAs and in nurse practitioners, with a physician leading that team. But it's a team approach, collaborative agreement.
And so, as I appreciate it, there's a push, and I think you've said this, there is a push every year to expand what non-physicians can do, not under the oversight of a physician. That this is sort of nurse practitioners being able to operate essentially with, not I say operate, practice medicine, not under the supervision of a doctor. Is that the big push coming this year from the nurse practitioners?
Well, it's interesting that you use the word practice medicine.
I guess they can't practice medicine, can they?
Well, it's kind of a confusing state in what independent practice, or the practice of what. They practice advanced nursing.
Okay.
And so their goal would be to practice independent advanced nursing practice, not necessarily medicine, but there's not a clear line between what's the delineation there, I think, and what the practice is.
Can they do some of that now? Or what can I guess a better question would be what can nurse practitioners do now, not under the supervision of a doctor? Is there any? Can they have any clinical work, or how does that? What's the law allow?
I think the law basically says that there has to be a collaborative agreement.
Okay. Now,
what they can do is within the scope of their training or their type of practice and whatnot. So, I think the argument at the Capitol is if we have independent practice, we'll go to places that physicians aren't, or we'll set up practices that are beyond. We just want to practice to the fullest of our scope, and I think they can do that now. I don't see that independent practice would basically add any opportunities that are not already there in the sense of the availability of access to care and patient safety. Now, could they go into some of the fringe processes, maybe, weight management, hormone therapy, IV therapy, or whatever that's not necessarily under the realm of a physician who they're collaborating with? But does that really add improvement to access to care or to safety?
Well, still with us in the studio is Dr. John Mitchell, the president of the Mississippi State Medical Association Board of Trustees. Dr. Mitchell, we were talking about this a little bit earlier. We've made some changes already in the law about collaborative medicine? I mean, it used to be, was it 15? You had to be within 15 miles?
15 miles was the old restricted process from the collaborating physician to the nurse practitioner that was, in an independent or freestanding clinic.
Okay.
That is no longer the case.
And now, statewide, you can be, and you gave this example, but I'll steal it. You could be in South Haven, but be in a collaborative agreement with a nurse practitioner in Biloxi if
Correct.
you wanted. Okay.
There is no mileage restriction anymore. With the electronic age, with medical records being electronic and telephonically, even video conferencing and whatnot, the mileage is not necessarily a requirement for collaborative arrangements. And, just to get it out of the way, I think very highly of nurse practitioners and PAs. They are a very valuable component to the team of care and add a lot of value in the sense of being able to have increased access and increased coverage. It's just that I don't think that safety and efficiency and et cetera is anything improved by independence. I think that, physician-led team is still the safe, appropriate, effective way to do team-based care.
And is it primarily in the primary care context where you see these sort of collaborative agreements, or do you have folks all over?
All over.
Okay.
And the way that collaborative arrangements are, sometimes it's within clinic arrangements, side by side, door by door, it's within, specialties, cardiology, gastroenterology, and whatnot. They all may be in the same building. Emergency rooms is the same way.
Really?
But you still have some freestanding or outside collaborative type arrangements. So it's not restricted to either being side by side or that, as we said, the distance is no longer there.
And am I right that the nurse practitioners essentially are pushing legislatively this year to be able to do a fair amount of that, not in collaboration with a physician? Is that the push this year?
Well, the push, as I said, generally has been yearly in the sense of trying to do away with the collaborative arrangement in the sense of independence of without necessitating that arrangement.
Okay.
And this year is no different.
Well, the Senate, jumping to another piece of legislation, the House, I believe, concurred in the Senate bill that would have, that streamlines the prior authorization process. I assume, but I should probably ask you, I assume that's something that MSMA is supportive of this year?
Very much so. We supported last year's prior authorization bill. It made its way to the governor, which vetoed it. And so we were dedicated to work with the governor and address whatever his concerns were and support those changes so that we could get some, relief for both patients and physicians. I mean, prior authorizations has been a burden for both physicians and patients because it delays treatment. And, there's most of the time, 90+% of the time, PAs are approved. And so it's just a labor-intensive process that's needed to be streamlined. The Senate and the House have, as you said, have muddled over the two different bills and have come to a concurrence. And my understanding is that bill now is headed to the governor's desk. That's
my understanding. So for people who are not familiar, what exactly is prior authorization in a medical context?
The prior authorization happens for both procedures as well as medications, in the sense that if it's something that the physician or provider, nurse practitioner, PA, whomever feels that this is a necessary entity, be it drug, procedure, or otherwise, if it's not within the realm of that insurance's coverage, oftentimes you have to go through the hoops of getting prior authorization before it's given.
From the insurer.
Asked for, urgent and emergent and routine type processes. So some of them may take a little bit longer. Whatever you fill out the whatever the prior authorization rules or requirements are, and you send it into the insurance. And it's for them, it's a means of controlling cost. And it's some of the medicines may be very expensive and not on their formulary, but oftentimes physicians feel that that's still the best product or best treatment, and oftentimes clinical studies support that, and so you end up having to go through the hoops in order to get that patient that appropriate care.
Yeah, I'd be curious. I mean, how much? It seems to me, and I've been seeing doctors, for 43 years now, going back to my pediatrician, but it seems to me you all spend a lot more time navigating insurance hoops than practicing medicine compared to the way it was 30 years ago.
Well, no doubt that things have changed over those 30 years, not only in the sense of the way practice, but the availability of the drugs, procedures, and whatnot. And as you said, it's not only the physician's time, but you have to have ancillary staff. And you spend a lot of your administrative staff time or other time filling out paperwork or submitting paperwork and whatnot that's not actually directed toward patient care. So a lot of the cost in patient care is really these ancillary processes, not the physician charge or whatnot.
Yeah, I have to think the amount of time you end up being forced to spend on paperwork, and maybe that's just the nature of the world these days, has to be frustrating if you remember a freer time for physicians.
Well, and it's not, paperwork's one thing, but repetitive paperwork is another thing. Whenever you fill out forms and whatnot and fill out additional forms, and when you fill out additional forms and then more forms, that's when the redundancy and the burden really becomes. If it's a streamlined process, the rules and et cetera, you can submit that, get approval in a timely manner. You can solve both sides issues, but this repetitive, redundant, ask for more and more is, needs to be addressed.
Yeah. What are the other focuses of the association this year as the legislative session really starts kicking off? Do you all have other bills that you're either supportive of this year or trying to make sure don't make it all the way through?
Well, one of the other really major focuses is advancing access to care to the working Mississippians, and we've been supporting that through both, Speaker White and Lieutenant Governor Hoseman had multiple conversations, and as you know, Lieutenant Governor Hoseman has a news article within the last few days that his bill will be coming out, in the sense of we don't know what exactly that bill is yet unless it's dropped since we've been here talking.
That's possible.
But we do know some of the major points, and we're in agreement that we need to increase the access to care because we're an unhealthy state, and we think that improving primary care access is going to be a major impact. The other thing is presumptive eligibility for pregnant moms, which has been moving through the House and the Senate, I think.
Wasn't there some effort on that a few years ago, or maybe just an effort to get that passed?
Well, there's been probably some talk of it in previous years. Last year, what was approved through the legislative process was the extension of the 3-month postpartum
That's what
to
I'm thinking
12
of.
months, which gave both mom and infant, the ability to receive care for that extended period of time.
So this would be about eligibility during the pregnancy.
Well, during and at the notification of pregnancy.
Okay.
The problem has been in the sense that if you were not on Medicaid and didn't have a payer source and you came in and were diagnosed as pregnant, you might not have any prenatal care for the first trimester or longer because it takes that long for paperwork. So now this would give you presumptive eligibility, which would then allow you to start treating in a preventive manner so that you're still working on the paperwork, but that there's not that delay in care.
My understanding is both the Lieutenant Governor and the Speaker are supportive of a work requirement for Medicaid expansion. Is that something the association has a position on?
I don't know that we have a position on that. We'll follow their lead. We know that in other states and in prior administrations, it's been there. It's been struck down. It's still present, I think, in the Georgia model.
I think that's right.
And we will see how this pans out. But, we are for the focus on increased access. They're focused on the mannerism.
Yeah. We've got about 15 seconds left. Any final thoughts, Dr. Mitchell?
No, it's hard to think sitting here in front of the microphone. I think that for the first time, I guess, in a long time with my interactions at the House and the Senate and et cetera, we have receptive ears. And I think that the focus on healthcare and globally healthcare, not just in extension of access and whatnot, but just in the discussion of healthcare in general, has been more positive and more receptive this year than it has been in many years.
Well, thank you for taking the time to be with us. This has been Dr. John Mitchell, the president of the Mississippi Medical Association Board of Trustees. This is Lucian Smith in for Paul Gallo here on the Gallo Radio Show on SuperTalk.